Hi, I'm Dr. Keshishian, and welcome to our podcast series, PPE, Podcast for Psychoeducation during the COVID-19 pandemic. Today, we're discussing how the pandemic has impacted contraception, abortion, and women's rights issues. I'm joined by Dr. Jennefer Russo, Vice Chair of Clinical Affairs for the Department of Obstetrics and Gynecology at Harbor UCLA, and the media editor for the Contraception Journal. Hi, Dr. Russo.
Hello.
Can you tell us a little bit about yourself?
Yeah, so I am an OBGYN. I actually trained at Harbor UCLA and then went on to be in practice for several years as a generalist OBGYN working for an FQHC. And then I did a fellowship in family planning and came back after that to California to become the medical director of Planned Parenthood of Orange and San Bernardino counties for 7 years. And less than a year ago, I came back to Harbor to be vice chair of clinical affairs and also to kind of lead up family planning initiatives in the department.
Wow, so you have a lot of experience in this area. That's great. Can you tell us a little bit about the barriers to contraception currently?
Yeah, well, I mean, right now we're seeing that we're trying to keep our patients out of our clinical spaces, away from face-to-face visits. And many of our patients don't want to, we want them to stay home in some cases, and they want to stay home as well, but that creates complications in accessing contraception. And so there's been a lot of innovation around this, removing the requirement for in-person visits, creating remote provision of birth control methods that are simply available by prescription, and then trying to create more access to injectables by teaching patients to administer injectables to themselves. That's coming soon, as well as trying to increase access to long-acting reversible contraceptive methods like IUDs and implants. So, we're trying to figure out ways that we can do phone visits and remove barriers.
Right, so there are a lot of challenges because some things just require an in-person visit, but then you're trying to work on things that would historically require an in-person visit, but how can we get creative about it, essentially?
Exactly.
So, given the pandemic, have you noticed that women who are coming to you or to other OBs are changing their plans on if whether or not they want to have children or contraception or kind of more family planning?
Yeah, kind of just on a person-to-person level, I've definitely seen patients who've changed their mind about a pregnancy. Our patients, they're facing a lot of challenges economically. People have lost work as a result of the pandemic and are facing really sometimes dire straits financially. And that always figures into patients' feelings about pregnancy and about their ability to support a child.
I read a statistic from the New England Journal of Medicine that stated about a quarter of American women will have used abortion services by the age of 45. How do you think COVID has impacted the ability to obtain, let's start with surgical abortion?
Yeah, so within our system, fortunately, it really hasn't. But in other healthcare systems around the country, abortion hasn't been seen as an essential service. And the problem with that is that it's time limited. We're operating under a tight timeline in many cases. And it therefore is something that's considered urgent or essential. National organizations like the American College of Obstetricians and Gynecologists opposes this resistance to seeing surgical abortion as an essential service. And so in terms of surgical abortion within our own system, I don't think that there have been issues. Fortunately, we are in a state where there's a lot of access to abortion services. Our Medicaid program covers abortion care. We have a lot of providers. In the majority of the country, close to 90% of counties have no abortion provider, whereas in California, it's somewhere closer to 50%. So that's still not great in terms of access, but it's way better than it is around the country where people are really limited in their ability to access services.
So, how do you think that discussion is going nowadays, especially with the resources that you just described and how limited they can be all over the country?
Yeah, I've had myself some really challenging conversations with patients about the reality of COVID testing and needing to have a COVID test to go to the operating room, needing to go to the operating room for a procedure, accessing services at private providers, and just figuring out timelines and how to get in. And, they have to be completely asymptomatic for COVID to be able to access services. So it's really challenging. And we know that our patients are used to jumping through a lot of hoops. Patients really will go through a lot of hoops to get to abortion services, more than many other healthcare services. So they're still doing it, but yeah, it's very challenging.
I can imagine having that discussion with a patient, especially over the phone, has its own set of challenges. How have you been navigating that?
By the time most patients come to us, they're pretty clear in their decision. But, we do still see patients who have ambivalence, and then have lots of conversations about pros and cons of continuing their pregnancy. That conversation has very much involved recently financial issues.
Mhm.
And, that makes things harder, because a lot of times patients feel like, I would continue this pregnancy if I could provide for this child, and I really do want a child, but all of these external factors are figuring into the situation. And I've had some really difficult conversations where, I'm sure in your field that the ambivalence is the issue. Like, most women feel fine after an abortion and feel very relieved. But if a person comes into an abortion with ambivalence, they have a higher risk of regret or depression. And so we really try to help them to clarify their decisions. And exactly, like, if they're calling in over the phone to have that discussion, that can be very challenging. But it's a challenge that we're used to dealing with. And I'd rather have the conversation over the phone and really clarify their feelings about it than make them come in and sit in the clinic to have that conversation. So we're trying to increase access in that way as well.
And I guess the key is really to have that open dialogue with your doctor and your healthcare team, so that you can make sure that you have an opportunity to kind of voice your concerns, or ask your questions, and make sure that you are making an informed decision.
Definitely.
Interestingly enough, we did a previous podcast episode on how the pandemic has impacted those who are experiencing abuse at home. With the stay-at-home orders, have you seen either an increase in the case of intimate partner violence or unwanted pregnancy as a result?
In terms of my personal experience, I would say that it hasn't particularly changed in terms of the patients that I've seen, but we know that there is definitely a higher risk of intimate partner violence in situations where there are stay-at-home orders. Some statistics were released by the United Nations that showed that domestic violence in France increased by 30% after their lockdown. During the first 2 weeks of lockdowns in Spain, the emergency number for domestic violence received 18% more calls. In the US, law enforcement has said that domestic violence cases have risen up to 35% in recent weeks. So this is unsurprising. Unfortunately, we think about our nuclear family structure and the fact that there are people who are stuck in families where there's abuse. And then you add on economic pressure and maybe the fear of leaving and going to a shelter or going somewhere more uncertain because of the risk of COVID. And so there are a lot of people really stuck in bad situations. And I just want our patients to be aware that we have resources for them. We can help them access those resources, and they should come to us to access help, basically.
Thank you for saying that. Let's talk about emergency contraception.
Emergency contraception can be accessed. I think everybody knows about Plan B, which is levonorgestrel as an oral emergency contraceptive. And then there's another emergency contraceptive that can't be accessed without a prescription, which is called Ella, or ulipristal acetate. Ella works a little bit longer after unprotected sex, but they're both very effective if they're taken before ovulation. So it's really important that somebody take it as soon as possible after they've had unprotected sex. And then if they're in the first 14 days of their cycle, it's better. Once they go past that day 14, if they have regular cycles and they've already ovulated, then it's not going to work. In that case, the best and most effective emergency contraceptive is a copper IUD. And so that requires an in-person visit, but is available in all of our clinics that provide contraceptive services. And then in terms of medication abortion, we are doing things to try to make that easier to access. The great thing about medication abortion is that it can be done up to 10 weeks of pregnancy. There are very few reasons why patients aren't candidates for it. It's very easy to use, and we're trying to make it easier to access. So currently, there are regulations that require an in-person visit to be administered the first pill, which is called mifepristone. We're working through advocacy organizations to try to remove that requirement. So I'm hoping that we end up in that direction, because that will provide access to people who live very far from a place where they could have a more procedural abortion.
Thank you for explaining that so clearly. It sounds like there are many different options, and that anybody who's in this situation, especially if you've faced any sort of intimate partner violence, an unwanted pregnancy, you're worried about your pregnancy, to reach out and ask for help from your providers, and that there are options to contraception, options for long-acting reversible contraceptions, injections, surgical abortions are still occurring, medication abortions, and trying to remove the barriers from that. So there are a lot of different options out there for people. And I guess the important thing for them to know is that to be able to make the best decision for what's appropriate for them is to have a candid conversation with their doctors about it. Do you happen to have a particular patient experience or success story that you could share with us?
This is a great question. I've seen patients who travel from very far distances to access services. So, I've seen patients that have traveled like 100 miles to access a medication abortion. And, when those patients find out that they don't have to come back for a second visit, it's really significant. They're very happy. And it means that they get to choose. Like, sometimes people will choose a procedural abortion because they just want to be done and they don't want to have to come back for follow-up. But this gives them sort of a balanced choice where they can really make the decision that sounds best for them, whether they want to have that experience at home with the medications or whether they prefer to have a procedure. So that's really positive. And then, I keep thinking about a patient that I saw who had two young children. She had a 3-year-old and a 1-year-old, and she got pregnant on purpose because she wanted to have another child. And then her partner lost their job, and they ended up in really dire financial straits, and she needed to make a decision to terminate the pregnancy so that she could take care of her 2 other children and really provide for them. But she was very sad, and really that wasn't the decision that she really wanted to make. And just sitting for a moment with her and hearing that and attending to her feelings and helping her process them was so powerful for her. She was very thankful. And these are the kinds of conversations that we have frequently with our patients, and life's very complicated. And I think abortion sometimes gets reduced to very black and white kind of, 2 poles of thought, instead of, kind of understanding the reality of people's lives, which is much more complicated.
There's a lot of gray in between.
Exactly.
What recommendations might you have for your patients or providers out there, given our discussion today?
Well, I think even if we just focus within our system, our healthcare system, I think it's really important that patients and providers know that these services are offered within the system, that each county hospital has the availability of services for abortion. And then for contraception, our ambulatory care network and all of our clinics and affiliated clinics have access to birth control. And we have guidelines system-wide that allow providers to provide birth control remotely, so over the phone, or even to get a depot shot, which is the injection, by like drive-through, like maybe drive outside and get the shot and never come into the clinic. So we're really making a big effort to try to increase access, and we're hoping that our patients will take advantage of it, and also that our providers are aware of it and they refer patients for services, and just that providers really kind of be in the mindset of reducing those barriers. So, not putting undue requirements for exams, or, using guidelines that we have that exist about medical issues in patients and what birth control they can use with medical problems. For example, there are existing guidelines through the CDC. Just really getting in the mindset of, we want to help people avoid unwanted pregnancies, because the amount of resources and time it takes for our patients to access services for those unwanted pregnancies is significant. And if we can prevent that in the first place, if they want to prevent it and we help them prevent it, we've decreased a significant burden.
Absolutely. Thank you so much for everything that you do. It's been an absolute pleasure.
Thank you for having me. I really appreciate it.